All right, good morning, everyone. Welcome to Chair's Grand Rounds for the 3rd of February, 2022. I'm Mark Carther, Chair of the Department of Medicine, and I'd like to welcome you all to 2 rounds. These are being broadcast over the webinar and will, as always, be recorded and presented on our YouTube channel if you wish to catch up with them a bit later. I'm actually, for the first time since the start of the plague, doing this from my house because I've got an event today which requires me to be online all day and I don't have time to get to the office. So we'll try this from home. I apologize in advance if my internet drops. It's not great, and Azim should be able to take over as host if that happens. I'd like to welcome everyone. Today's presentation is by Dr. Azim Gangji, who I think probably everybody knows in the department, but Azim is a transplant nephrologist from St. Joseph's Healthcare and has been here for many years. He has had numerous jobs of importance in the department, including the director of the nephrology program, then the chair of the subspecialty program committee, and has more recently become the vice president of education at St. Joe's, where he's been helping us with a whole bunch of initiatives going on right now, keeping the hospitals focused on the academic mission. Today, Azim is going to talk to us about membranous nephropathy, so I'll turn it over to Azim. And as always, we will have question and answer time at the end. I prefer you to put questions and answers in the question and answer box rather than the chat box, because the chat box becomes hard to track down. But if you can't access the Q&A box, then please feel free to use the chat. Thank you. Azim.
Thanks very much, Mark. Thanks for the introduction. Hello, everybody, and thanks for joining on this snowy morning. Appreciate you taking your time to listen to this talk. So my talk is on membranous nephropathy, a story to be told. And a lot of work has been done recently on membranous nephropathy, and I thought this would be a nice way to update all of you in medicine about what's happening, because it does have some overlaps in different autoimmune diseases as well. So my goal hopefully is to go over a bit about the epidemiology, clinical features, the natural history. I'm going to spend a lot of time on the story of membranous nephropathy, review some of the complications, and then very briefly do treatment options. So if you remember, membranous nephropathy is part of the nephrotic syndrome category. If you break up nephrotic syndrome into primary and secondary, membranous nephropathy falls into the primary category, along with some other ones that you are aware of: minimal change disease, FSGS, MPGN, and IgA. But the focus of this one is membranous. So I'll start with 3 cases, and I'll come back to these cases at the end. So this is a 49-year-old male that had presented with really intractable volume overload, anasarca, really severe proteinuria, was anti-PLA2R positive, and I'll discuss that later in the talk. Very refractory to multiple modes of therapy, developed end-stage kidney disease, and is now up for kidney transplantation. Second case is a 61-year-old male, proteinuria of 22 grams per day, and also a significant hypoalbuminemia and sarca, and had developed actually a pulmonary embolus, also anti-PLA2R1 positive, and just a brief discussion about the management. And then we have a third case, a 71-year-old female, proteinuria between 2 to 3 grams per day, a normal albumin, anti-PLA2R1 negative, and discuss her management. So as far as epidemiology of membranous goes, it's really present in all races and ethnicities. It has an incidence of about 1 case per 100,000 persons per year. It's typically more common in male patients. And the median age of onset is in the early 50s, although there's really quite a wide distribution of age. It rarely occurs in children, though. About 30 to 40% of membranous patients will develop end-stage kidney disease within about 5 to 15 years of onset. The potential mortality and morbidity associated from membranous is really due to increased risk of complications such as infections, cardiovascular events, including venous thromboembolism, as well as malignancies. So as far as clinical features go, the kidney clinical presentations are very similar, whether you have primary membranous or secondary forms of membranous, as they both essentially present with nephrotic syndrome. And if you remember, nephrotic syndrome characterized by heavy proteinuria of more than 3.5 grams per day, hypoalbuminemia, edema, anasarca, dyslipidemia, and lipiduria. And these features tend to develop slowly and can really be overlooked for months, unlike more acute presentations of other nephrotic syndromes, such as minimal chain disease, which essentially is quite abrupt. Membranous nephropathy in the early course of disease can have an indolent course as there is a gradual but progressive development of immune deposits and then subsequent podocyte injury. So the proteinuria appears as the disease progresses, as I said, often over months to years, at a fairly subclinical level prior to the diagnosis. The extent of proteinuria is really quite variable and can be subnephrotic or as high as 20 to 25 grams per day. About 80% of patients will eventually present with nephrotic syndrome, and the remainder are really diagnosed earlier in the course of disease, usually after an incidental finding on a urinalysis. Microscopic hematuria can be present, usually about 1+ or less, unless you have evidence of renal vein thrombosis, in which case it's higher. And as far as the timing of membranous goes, it really depends on the offending agent or the underlying disease process, because that can sometimes predate the membranous by months to years. Whereas in other cases, such as, for example, malignancy or autoimmune disease, such as lupus, the nephrotic state can actually be induced by membranous, and so they will often present together. So the natural history over here is that it's actually quite variable, and really the available parameters that we have are not too helpful in predicting the course of disease, and that does make management difficult. So even patients who are highly nephrotic may actually undergo spontaneous remission. But these individuals, based on the guidelines, are often treated with immunosuppression to avoid adverse consequences of prolonged nephrotic state. On average, there's a rule of thirds. So 1/3 of patients will exhibit a spontaneous remission. 1/3 will stay the course. So basically, they will not remit, but then they will not worsen. And about 1/3 to 40% will progress onto end-stage kidney failure. And really, the proteinuria, for you to, for example, to achieve partial remission, it actually can take up to 15 to 20 months. And in fact, complete remission can take 25 to 40 months. And this becomes a barrier to studies, because often the studies are not as long-term as we'd want them to be. Anytime, the one point to take away is that anytime you do remit, whether it be spontaneous or induced by immunosuppressive therapy, it's beneficial in regards to kidney survival. So in contrast, when you have cases that remain nephrotic, these ones can progress to kidney failure over time. 2 independent trials demonstrated a 35 to 40% rate of reaching kidney failure in patients treated conservatively, as opposed to being treated with immunosuppressive therapy, primarily alkylating agents alongside a corticosteroid regimen. The time frame for membranous to resolve, again, over time is really quite long, as I had mentioned earlier. And so patients often can experience a partial remission, and in most studies, this is identified as a 50% reduction in proteinuria from baseline to less than 3.5 grams per day, or experiencing complete remission, which is less than 0.3 grams per day, assuming over here that no long-standing damage has occurred, because otherwise you will still spill protein, but can still be in remission. And so again, as I mentioned here, long-term studies are required. Membranous can relapse in about 1/3 of the cases. So once you've undergone complete remission or perhaps partial remission, you can remit. There's a theory that perhaps a relapse is higher after partial remission and may actually reflect incomplete suppressed immunologic activity. And as we've learned more about membranous and how it is developed, it may be that we will be able to reduce these relapses in the future. In secondary membranous, the treatment of the underlying disease or cessation of the offending agent, for example, should result in eventual remission. But again, it still takes that same time frame of months to perhaps sometimes even years for the proteinuria to dissipate. An example of a secondary membranous is class 5 lupus nephritis, which really has an excellent prognosis of kidney survival rate of 72 to 98% over 10 years. So let me tell you more about the story of membranous nephropathy. So it all starts back in 1946 when Dr. Bell was the first to identify membranous nephropathy as a type of glomerular disease, and at that time it was called membranous glomerular nephritis. And what he saw was a thickening of the GBM, and in association with that, he noted marked edema and proteinuria. In 1956, Mellors and Ortega identified immunoglobulins in the glomeruli deposits using immunofluorescence. And this is the first time that all of a sudden the idea of an immune complex was raised. In 1957, Jones demonstrated the presence of silver positive rods projecting from the glomerular basin membrane using the specific stain. And really this was, in retrospect, GBM that was surrounding the deposits, so the basement membrane that was actually surrounding the deposits. In 1959, Movet defined the causal relationship between thickening of the GBM and this protein deposition between the glomerular basement membrane and the podocyte using electron microscopy. So by the late 1950s, you had identified the pathological kind of characteristics of what membranous nephropathy is. In 1968, Enrich identified the 4 stages of glomerular lesions in membranous nephropathy, and these are pathological stages. So stage 1 consisted really of just a few subepithelial deposits over here, such that the GBM really appears normal or just slightly thickened, but no other evidence of any other disease activity. So this would be fairly early in the disease course. Stage 2, for example, over here, now you see spikes protruding out. So these glomerular basement membrane material sticking out there. And in between, you see immune deposits, the dark immune deposits there. In stage 3, what you now have is a GBM that's encircling the entire immune deposit over here. You can see the dark immune deposits and then the GBM encircling it. And this is typically associated with heavy proteinuria. In stage 4, what you really have is kind of a resorption of those immune deposits and an irregularly thickened glomerular basement membrane, usually signifying complete remission. So there were 10 really important studies of membranous nephropathy to identify its etiology. And a very important study took place that really goes on to serve as a basis of learning about the pathophysiology of membranous nephropathy was by Dr. Heyman, and he created the Heyman nephritis model in 1959. I want to spend a little bit of time on this. In 1959, an animal model that mimicked human membranous nephropathy was developed by immunizing rats with tissue components of the proximal tubular brush border cells. And what happened was that the rat, once injected with this, developed antibodies, and there was deposition of these subepithelial immune complexes over here. Okay, so you see the podocyte over here, you see the GBM over here, and here's the antibodies, and there's basically these immune complexes that are depositing over here. Now, at the time, it was felt that this was caused by circulating immune complexes as this brush border antigen called FX1A and its antibody were simultaneously present in glomerular deposits, and they were also present in the circulation. And the development of immune complex was found to be coincident with these glomerular deposits. And so this was the prevailing theory of the Heyman nephritis model in the late 1950s. So in 1978, Koser proposed that membranous nephropathy had a podocyte target antigen. Okay, and this again starts to really shift things across as from the circulating immune complex model to the podocyte antigen model. At the same time, Maker identifies that this particular antigen is a mannose containing glycoprotein, and which may be able to bind complement. So, as I said, in 78, Koser and Hodeker induced the Heyman nephritis pathological changes in isolated rats using these anti-FX1A antibodies against those brush border antigen antibodies. And they suggested that the membranous was not caused by deposition of these larger immune complexes, but instead by in situ immune complexes that were formed by these autoantibodies. So now what you actually have over here is that there's an antigen that's identified over here in the podocyte, and the antibody is actually crossing the GBM and actually going to bind to the antigen on the podocyte specifically. And Maker further confirmed that this particular podocyte antigen was a mannose containing glycoprotein, but really they didn't know exactly what it was. In 1982, Kershaki then goes on to identify this particular molecule as megalin, and it's identified as a rat podocyte antigen, which is present on the membrane there. And the pathogenicity of the megalin was related to this glycosylation. So if it wasn't glycosylated, it actually wasn't pathogenic, but if it was, it would then become pathogenic and antibodies would form towards it. It also was identified that megalin contained multiple epitopes, and then really demonstrated this intramolecular epitope spreading, such that the more epitopes that were present, the rat would have worsening proteinuria. There was also some evidence of intramolecular epitope spreading with the development of autoantibodies to a molecule called plasminogen, which is a known ligand of megalin, and suggesting that these autoantibodies bind to podocyte intrinsic antigens, again, both all in situ over here, okay, in the glomerular subepithelial space, and not as circulating immune complexes that are being deposited. This now sets everything up for the search for a human podocyte-specific target antigen, because until this time, there is still no evidence of a human-specific podocyte antigen. So a few other important studies during this time period take place while in search for the human-specific podocyte antigen. So the role of complement comes into play. So, now that you have the complex the antibody depositing in situ, binding to the antigen in the podocyte, how is the damage actually occurring? And the prevailing theory at the time was complement activation. And so in 1980, David Salant did a study, and he found that C3 deficient rats did not develop proteinuria after receiving anti-RAD FX1A antibody injection, which should have actually induced membranous nephropathy. Keep this gentleman's his name in mind. He becomes a pivotal player in the future as well. Also, Koser in 1985 proposed that C5b9 caused proteinuria through its non-dissolving activity. C6 or C8 deficient rats also do not produce a proteinuria. So Cybulski shows it in a different study by limiting your membrane attack complex, how you could actually prevent the formation of the development of proteinuria. Oshatsky confirms podocyte absorb the C5b9 and discharge it into the urine, and his urinary levels, membrane attack complex that was related to worsening of membranous nephropathy, as shown by Kahn in 1995. So now we have a story that's being built where complement activation is felt to be the mediator of the damage that occurs in membranous nephropathy. So around this time period in the 1980s, there's also the other theory that could this be a pre-planted antigen that could also be doing it, okay? And Batsford and Border created a membranous nephropathy animal model by an IV infusion of a cation exogenous serum. And they specifically used a positive cation over here because they felt that the GBM was negatively charged, and then that this antigen therefore would cross the GBM and perhaps localize in the podocyte. And so they were able to show that this antigen they could bind to circulating antibodies and then in situ form immune complexes similar to what has been present over here, except it's not an intrinsic podocyte antigen. In humans, there was actually a model that was demonstrated to have this, a cationic bovine serum albumin that was present in milk products. And what was happening was that these children were developing early childhood membranous nephropathy as this particular antigen was being deposited into the podocyte area, but it was not a a native antigen, but it was an extrinsic antigen. So this is the first time now over here where we're talking about perhaps a pre-planted antigen binding an autoantibody. So now we discussed all three different phases over here of how the antigen is developing, and we've talked about the importance of the membrane attack complex with respect to complement. So the story plot over here thickens, and what comes next. So three major parasite antigens were found in humans in membranous nephropathy. So in 2002, Pierre Ronco becomes a pivotal player in the game over here and identifies neutral endopeptidase as the first human membranous nephropathy parasite antigen. So to understand what he did, you kind of have to understand a bit about alloimmunity, and this is always very dear to my heart as it crosses over transplantation and GN. So alloimmunity develops when there's a discrepancy between a host and recipient antigens, and is characterized by an immune response to a previously unfamiliar antigen. So an example of this is an organ transplantation, such as rejection. So an antenatal alloimmune membranous nephropathy was described in mothers that were genetically deficient in this particular antigen, parasite antigen called neutral endopeptidase. And what happened was these moms were immunized against this particular protein. And then therefore, this circulating antibody to neutral endopeptidase crossed the placenta and targeted the baby's NEP antigen on the fetal podocytes and therefore the neonate developed membranous nephropathy, which eventually recovered when the fetus was no longer, the baby was no longer exposed to the maternal antibodies about 11 months later. So Pierre Ronco describes this very nicely over here. So what happens over here, so you have the baby in the mom's pregnancy. The placenta has the presence of both maternal and paternal antigens. And so what the mom sees over here is a paternal NEP antigen on the placenta. And because of that, the mom now goes on to develop NEP antibodies towards that placenta. In the third trimester, there's a transplacental transfer of these anti-NEP IgG1 antibodies, and now these go on to bind to the baby's kidney and to the specific podocyte area. And so what you end up over here is that you have the podocyte membrane, you have these NEP antibodies that the mom developed against the placenta, and this activates the classical pathway when you have the antigen in the kidney binding to the antibody that the mom has, activates C1q, and this then leads to complement activation, and the child develops membranous nephropathy. Once the antibodies are removed from the mom, so where the child is delivered and no longer exposed to those antibodies, the membranous nephropathy actually resolved totally. And like I said, about 11 months later. So this was really exciting. So you discovered the first antigen, but then in 2009, probably the most important study in membranous nephropathy takes place. And they identified this, Beck and Salant, the individual that was looking up a complement before, identified idiopathic membranous nephropathy, the PLA2R antigen. So in 2009, like I said, Beck and Salant identified this, and they published this in the New England Journal of Medicine. And this was really a wonderful study that they did over here. They identified with biopsies over here of human glomeruli. And what they identified over here was that the pattern of membranous nephropathy and PLA2R deposition, the immune complex that was occurring, was identical. And they also go on to say that in patients who had secondary membranous nephropathy to such as hepatitis B or to malignancies or to autoimmune disease such as lupus, were not positive for PLA2R1 call. And so these antibodies were detected in the serum and then identified in deposits of the GBM of the glomerulus, so really on the subepithelial space. He also showed that 70% of adults with primary membranous nephropathy, okay, exhibited these not IgG1s, but IgG4 antibodies against M-type phospholipase A2 receptor, or easier said, PLA2R1, which is expressed on the podocytes. So now this really revolutionized the way we would think about membranous nephropathy, substantiating what Pierre Ronco had demonstrated earlier with NEP. And so here's a bit of a mechanism. So a different diagram, but so you have this subepithelial deposits. So you have, subepithelial podocyte antigens, which is the PLA2R receptor over here. And you have these anti-PLA2R1 antibodies that go and bind, go across the endothelial space, across the GBM, and bind specifically to the antigen on the podocyte, and go on to form membranous nephropathy through complement-mediated damage that occurs, damaging eventually the slit diaphragm as well as the actin cytoskeleton. So this diagram is just showing exactly that. So you have a normal foot podocyte structure over here. You can see a wonderful slit diaphragm. A nephrin is present there. Podocytes there anchoring as well. The cytoskeleton is intact. No concerns over here. Once you have the antigen-antibody complex activated, let's say in this case PLA2R bound to an antibody, it activates complement. Complement now is going to disrupt the cytoskeleton as well as cause damage to the slit diaphragm, and you have this massive albumin that leaks across the slit diaphragm. And at the same time, what you have is with the damage to the actin cytoskeleton, basically what happens now is that you get effacement. So the hand holding or the finger holding podocytes that are on the GBM are no longer holding each other, and in fact they totally collapse. And so often on biopsies, the pathologists and the nephropathologists will call this effacement of the podocyte foot processes. Okay, so now we've discovered PLA2R1. We've discovered NEP, but then the question becomes, is there a genetic predisposition? Because now we're thinking this is more of an autoimmune disease. And so autoimmune diseases often have an association with HLA. And so again, similar to many autoimmune diseases, there is a heritable component of membranous nephropathy and a strong link to HLA locus, which is on chromosome 6. So it's identified that in Caucasians, DR3, the class 2, DR3 was identified as a risk allele for membranous nephropathy. In the European GWAS study, it identified an association of class 2, again, HLA DQ alpha 1 locus. And really homozygosity at the DQ alpha 1 locus conferred an odds ratio of developing membranous nephropathy of 80-fold. In China, their studies had identified, again, additional class 2 alleles that were specific to the Asian population, being DR beta 1 and DR beta 3. So now it's suggested that there's a genetic risk or a predisposition at the HLA locus. Now, that doesn't mean that these specific HLA loci are always leading to worsening of or predisposing you to membranous nephropathy. In fact, there are probably other HLA loci that actually discourage presentation of these antigenic peptides and therefore downregulate the immune system in developing antibodies to PLA2R. So now comes the idea of epitope spreading. So if you remember back in the animal studies, there was discovery of epitope spreading. And so the question is, does epitope spreading also occur in humans? So so Shaw in 2007 had discovered in a wonderful experiment how megalin through epitope spreading would become a resistant disease, where they would actually have worsening nephrotic syndrome and very resistant nephrotic syndrome. So an epitope is, by definition, is an antigenic determinant or a site on the surface of an antigenic molecule to which a single antibody will bind to, or what an antibody defines as is this kind of irritant area. And so epitope spreading refers to the development of an immune response to epitopes distinct from and non-cross-reactive with the original disease-causing epitope. And I'll show that to you in a diagram, but it's a different part of the molecule that is becoming antigenic. That's the bottom line. So the autoimmune responses begin reacting with the outermost epitope of the target because that's easily displayed. But then as tissue damage occurs, these antigen-presenting cells will then start to pick up inner epitopes, and this results in secondary or more resistant disease responses. So the exact same thing happens with PLA2R. So here's a single epitope, no evidence of spreading on the cysteine residue over here of membranous nephropathy. So this is the outer chain of PLA2R, very small component of intracytoplasmic portion. So this chain is now hanging out there on the podocyte, and you've now developed an antibody towards this cysteine residue. As further damage occurs, you now start to develop additional presentation of inner epitopes, and now start to protrude out and now be recognized by the antigen presenting cells. So these are in the domains of CTDL1 to CTDL7. And as the disease progresses, you now seem to have multiple epitopes. Okay, and now what you have is what's called intramolecular spreading. And so clinically, what happens over here is that these individuals with multiple epitopes have worsening proteinuria. They actually tend to be older individuals, and probably because they have poor repair mechanisms. So therefore, their inner epitopes get displayed more so and for a longer period of time. And then with that, the likelihood of remission decreases significantly as well, and what we call resistant disease develops. So what causes epitope spreading? Like, why actually does this occur? So I alluded to some ideas, such as trauma, but you can also be secondary to infection. There could be a component of molecular mimicry. There could be non-specific activation of the immune system, such that the antigen-presenting cells are activated. It could be because of an imbalance of regulatory cytokines. I think anytime we present a lot of different ideas, it usually means that we don't really know very well. But ultimately what happens is the antigen-presenting cells do pick this up, activate the adaptive immune system, and this eventually leads to autoimmunity and organ damage. Okay. So we talked about the epitope spreading, and one epitope damage leads to second epitopes, third epitopes, and so forth. However, there's immunosuppression over here can also do the opposite, where it can actually prevent epitope spreading. And they've demonstrated this in an animal model where they've downregulated anti-inflammatory cytokines and upregulated some Th3 responses. And therefore, what you see is that there's a halt and downregulation of the immune systems, and therefore you don't have any further epitope spreading as well. And that perhaps might account for potentially other individuals having a lesser risk of relapse. So how do these anti-PLA2R1 antibodies form anyhow? Like, where did they come from? And so nobody really knows, but there's a group in China and researchers over there had identified a significant correlation between membranous nephropathy and the air pollution that had developed there. And they've identified these particulate matters, this particular one called 2.5. And what they have proposed is that this particulate matter, which is a very small one given its particulate, will enter the airways and the alveoli and cause an inflammatory response over here, okay? And this inflammatory response will activate neutrophils and alveolar macrophages and airway epithelial cells. And it's felt that these cells, actually, these neutrophils and APCs, may harbor PLA2R1 there. And so now what happens is that this PLA2R is expressed in this oxidative stress and inflammatory environment. The PLA2R molecule antigens, aside from for example, the basic outer antigen, but in fact, some of the internal hidden antigens might get displayed because of the epitope spreading. And now you will develop antibodies towards the PLA2R, which then eventually goes down to the kidney, who becomes a bystander effect, and the damage is done to the kidney at the podocyte level, but all because of the air pollution over here. So this hasn't been proven, but this has been proposed given the high risk of membranous that's developing in China. So is there a relationship between the immunologic and clinical course of disease? So basically, now we've identified PLA2R1. It's actually available as a serologic test, so we can order this now. But does it actually correlate with disease activity? So, irrespective of how the tolerance is broken, okay, we do know that if you have low levels of anti-PLA2R, okay, it's in different phases as to when this is occurring. Okay, so initially you have low levels of anti-PLA2R when the disease is first occurs. And later on, it will then begin to circulate and then soon find abundant antigen in the glomerulus. And it's a process of evolution over here. So and I think maybe this is better explained over here with this diagram over here. So initially, you get exposed to anti-PLA2R, the antibody, okay? It then goes on to bind at the tissue level. So in fact, there's nothing in the circulation. And the N-terminal portion of the PLA2R antigen, okay, is a major irritant for the immune system. So it tends to, the antibodies tend to cluster in the kidney. And so almost, it's as if the kidney acts as a sink, okay? So at this point, you will not detect any serum anti-PLA2R level. However, if you were to do a biopsy, you may be able to detect tissue PLA2R being present. As the disease progresses, okay, and the antibody levels increase as well, and the damage at the podocyte worsens, the serum anti-PLA2R level will now increase over here. And then as damage occurs, gradually the proteinuria will start to worsen and worsen. And so often this is still quiet. Patients are not aware of any evidence of significant proteinuria, so no evidence of nephrotic syndrome. And then eventually they will present somewhere along the way here where they will be severely nephrotic and will seek help. And at this point, either the disease resolves on its own or starts to undergo partial or complete remission, or you may use immunotherapy. And at this point, what happens is that the PLA2R levels will gradually fall. But look at the proteinuria. It actually will persist and persist and persist over months to years, just as was proposed earlier. And so even partial remission, and the proteinuria will persist. So PLA2R levels essentially will come before the proteinuria, and they will disappear earlier, and the proteinuria will gradually dissipate over time, but that doesn't mean that there's active disease there. Again, looking at more of a tissue level from a different perspective, again, no proteinuria, but you have the antibody initially that's present in the made by the plasma cells, and that's causing a damage at the podocyte level. You can see the slit diaphragm and the podocyte being damaged over here. And now gradually you're going to start having worsening of worsening proteinuria, and the patient will present somewhere along the way here. At later stages, the disease, there will be remission of the disease activity. However, the proteinuria will persist because these foot processes and podocytes are still quite damaged, so the proteinuria will continue on, but yet the PLA2R will be negative and immunologic activity will have come to a halt. So now repair will take place over a course of months to years until eventually you have remission and resolution of the proteinuria, or at least assuming that there wasn't significant damage done. So are there other antigens that have been identified aside from PLA2R? Well, actually, there's a host of them that have been discovered in the last 5 years or so. One that was called Thrombospondin was discovered in 2014. It had an association with malignancy. Another one that was just discovered recently, NEL1, also has a close association with malignancy, but 30%, and it's felt to be produced by the tumor cells. And you can see a whole host of these other ones being developed. Exotosin 1 and exotosin 2 have an association with lupus, specifically class 5 membranous. So again, we're learning more about these, but it looks like membranous nephropathy now we can say is more of a autoimmune antigen antibody disease. So are there secondary causes of membranous? So the answer is yes. Again, lupus I've mentioned, so immune diseases, so lupus can do it, rheumatoid arthritis, Hashimoto's, Sjogren's, psoriasis, sarcoid can all do it, including IgG4-related disease. Infections such as hepatitis B being the predominant one. HIV can also predispose to membranous. Drugs such as penicillamine, as well as heavy metals, can predispose to secondary membranous. Variety of cancers, tumors and lymphomas, and then other less common things such as sickle cell disease and hematopoietic stem cells transplant do it. And remember, I told you that the clinical presentation is no different, so it's hard to tell if it's a secondary or primary from what you have clinically. But what's the mechanism of that happening? So now this one is thought to be more of an exogenous antigens that have been associated with specific forms of secondary. So an example over here from an infectious perspective would be hepatitis B or syphilis. So in hepatitis B, it's been identified or at least attributed that subepithelial deposition of the Hep B antigen and then associated anti-Hep B antibodies are causing membranous when the antigen deposits in the subepithelial space, and then antibodies go there and bind to it. Malignant tissue, so thyroglobulin in thyroiditis has been associated with membranous nephropathy. And then also there was a tumoral expression of thrombospondin that demonstrated a possible link between cancers and this. So an example of this was in gallbladder cancer, which actually was expressing specifically thrombospondin, which is then going into the subepithelial space, leading to membranous. So seems like this free antigen becomes localized under the podocyte, and then it serves as a nidus for immune complex deposition. Okay, so just to kind of recap over here the story. So at present, we don't actually have any evidence of immune complexes being developed, okay, in human in the human through the human model that was proposed earlier. We do have lots of evidence now that this is an antigen that's an antigen that's present in the subepithelial space in the podocyte, and an antibody is going there and forming in situ immune complexes, and both neutral endopeptidase and phospholipase A2 receptors are examples of that. And then we do have an example of cationic bovine serum albumin that actually is a planted antigen that goes there, and antibodies therefore go and bind to the planted antigen. And probably over here, I would say thrombospondin can potentially act as well, being expressed by the tumor cells. Okay, so very briefly, I want to just spend about 5 minutes on cancer because it's a long-standing association with cancer. So first of all, the question is it actually true? And so this is a systematic review done by Leaphorn and published in 2014. And it summarizes the prevalence of cancer-associated membranous as well as patient characteristics and types of cancer. So what they identified was that the overall, from their meta-analysis, the prevalence of cancer was 10%. However, do note that there was significant heterogeneity in this. Most of these individuals who present with cancer were in the 6th to 7th decade, with the mean age being 66. Males had a greater presentation of cancer, with almost 2/3 of those having cancer. Of all the cancers associated with membranous, the cancer that was discovered before the diagnosis of membranous was only present in 20%. So the majority of the patients, the cancer was diagnosed at the time or following the diagnosis of membranous nephropathy. The vast majority of the tumors were solid organ tumors. Lung cancer was the most common, but you can see over here, prostate cancer, colorectal cancer, breast cancer were all present. Initially, it was felt that hematologic malignancies were not a major aspect of causing membranous, but you can see over here 14% were hematologic malignancies. Cancer and membranous nephropathy. So the development of cancer and the degree of proteinuria, there was actually no association that was identified by that. Only one study looked at the median time to cancer diagnosis, which is 5 years, which suggested there's a predilection of cancer in patients with membranous, and it persists for many years. So you kind of have to keep on following this as well. I think I've got a few questions. I'll answer those questions if it's okay with you as soon as I'm finished. Beck has proposed 4 mechanisms because it's really, the pathogenesis of this is really unknown. One is that antibodies may be created against a tumor antigen, and which is immunologically similar to an endogenous podocyte antigen, such as, let's say, PLA2R or thrombospondin, and this leads to in situ immune complex formation. The tumor itself sheds antigens that form circulating immune complexes that are subsequently trapped in the glomerular capillary wall, but we have very little evidence of that. Circulating antibodies may actually react to the tumor antigens that already have been planted in the subepithelial locations. And an extrinsic process such as a viral infection or an underlying abnormal immune response may be responsible for both the cancer and membranous nephropathy. But again, the mechanism hasn't really been proven. There are some pathological findings that can be helpful. So there's strong immunofluorescence staining of glomerular PLA2R, IgG1 and IgG2, for example. can be seen with cancer-associated membranous, whereas the dominance of IgG4 would favor idiopathic membranous nephropathy, so looking at subtypes of immunoglobulin G. In addition, the presence of more than 8 inflammatory cells infiltrating the glomeruli seems to also strongly increase the likelihood of cancer in patients with membranous. And so KDIGO has come across with general guidelines of doing a fairly extensive cancer screen, looking for secondary causes, but also looking for malignancies. How about hypercoagulability? So nephrotic syndrome, it on its own is kind of a thrombophilic milieu due to a variety of elements such as loss of coagulation factors in the urine, altered platelet activity, intravascular volume contraction, venous stasis, edema, and chronic inflammation. And so Barber from the Toronto GN registry attempted to define these disease-specific risks of clinically evident VTEs in patients with idiopathic glomerulonephritis after adjusting for some of the common thrombophilic risk factors, and also glomerulus-specific ones such as proteinuria, hypoalbuminemia, and malignancy. And so the registry, the Toronto GN registry was established back in 1974. They looked at patients who had idiopathic IgA, FSGS, and membranous. Exclusions were individuals who were younger than 16, who had incomplete data or less than 12 months, and about 1,300 patients, including 370 with FSGS, 540 with IgA, and 395 with membranous, had appropriate follow-up of about 63 months. And the major result over here is that patients with membranous tended to be older, male and Caucasian, but had more severe proteinuria and hypoalbuminemia, and better renal function at time of presentation. Cancer either before, present, or during follow-up occurred in 3.7%. There was a trend towards a higher number of cancer events in membranous, but this was really not significant, but did come close. And a greater proportion of patients with membranous had higher grade proteinuria, more than 8 grams per day, as opposed to the other diseases. So you can see from this graph over here that there's a greater number of events, VT events that occur in membranous, especially in the first few months. And so basically, as compared to FSGS or IgA nephropathy. So FSGS is a purple line, IgA is a reference line over here. You can see FSGS also has a higher risk of VT events, but less so. And even when you remove isolated renal vein thrombosis, which tend to occur in membranous still had a higher rate of VT as compared to FSGS or IgA, 4.8% versus 2.7 and 0.36. The median time was about, I would say, 7 to 8 months. And overall, 57% of the VTs occurred within the first year and 70% within 2 years. Univariate analysis initially identified male sex, proteinuria at presentation, as well as time average proteinuria, and hypoalbuminemia as associated with VTs. And in univariate analysis, cancer was identified as a potential risk factor. However, when they looked at in a multivariate analysis, only sex and, that should say multivariate, sex and serum albumin were associated with the increased risk of VTE, and cancer and proteinuria dropped off. And even though patients who had a higher level of proteinuria, it was a lower serum albumin that actually predicted VTE. Okay. So Leonke looked at this in further. So this time what they did is the Toronto registry was combined with the Glomerular Disease Collaborative Network from North Carolina. And they did a retrospective analysis of a larger cohort of patients between 1969 and 2007. Patients with secondary causes were excluded, and on the overall median follow-up time was 37 months. So this is the two cohorts going forward. And the frequency of VTE was about 7%. Okay, at the time of VTE, the mean serum albumin was 22.6 grams per liter. Thromboembolic events occurred in, so there were about 26 cases of renal vein thrombosis, 21 cases of DVT, 27 cases of PE, and 7 cases of VT at other sites. And 10 patients actually had simultaneous multiple areas of VTE. So given that albumin was coming out to be the major player over here, they looked at this in further detail. So once they identified the time to VT, which is generally about 3.8 months, Again, similar to the other study, 70% of the VTs occurred within the first 2 years, okay? However, even though you may think that this is more progressive disease if they present with a VT and a higher risk of kidney failure, in fact, there was no higher risk of end-stage kidney disease in those who experienced a VT and those who did not experience a VT. So the focus on albumin, and so what they did over here is they looked at albumin specifically, and they determined that each 10 grams per liter decrease in albumin, there was about a 2-fold increased risk of VTE. In further, further looking at albumin, okay, they looked at a value of 28 grams per liter and showed that there was about a 2.5-fold increased risk of VT if the albumin is 28 or less. They identified that there was about a 6-fold increased risk of VT if the serum albumin was less than 22. And so there's a calculator that's developed around this now to help us determine whether somebody should consider, where we should consider anticoagulation. However, I think below 28, you start to really need to start thinking about anticoagulation. Okay. So hypoalbuminemia is a risk factor for VT. So initially we thought it was all because of proteinuria, but it seems that that's not the case. So, but yet hypoalbuminemia is linked to proteinuria because you do lose a tremendous amount of albumin in the urine. But hypoalbuminemia can occur because of other mechanisms. So it has been associated with inflammation, nutritional status, permeability, protein permeability, but other factors, specifically with coagulation, it's been associated with overproduction of fibrinogen, factor 5, factor 8 as composite responses to hypoalbuminemia. There's a deficiency in plasma antithrombin 3 that's been shown to correlate with the low albumin level. Albumin is a cofactor for plasminogen, so the binding of plasminogen to fibrin and their interaction with tissue plasminogen activator. So patients with the membranous therefore have a 6-fold increase in plasminogen activator inhibitor, but not plasminogen activator, so suggesting suppressed fibrinolytic activity. And hypoalbuminemia has also been associated with hyperaggregability of platelets. So very briefly, I'm going to spend 2 minutes on treatment over here. Treatment over here gets complicated because patients are classified as low risk, moderate risk, high risk, and very high risk. And so depending on the amount of protein that they're spilling in their urine and what their kidney function is, you can then classify them accordingly, and based on that, decide to either follow the patient conservatively because they can undergo spontaneous remission or start to consider immunosuppressive therapy. And so if they've been described as low risk, it's really a wait and see. So use conservative measures such as ACE and ARBs, consider anti-hyperlipidemic agents. Moderate risk is wait and see. But if things do worsen, then you can start to consider rituximab or calcineurin inhibitor therapy. If they're high risk, there's now data for rituximab, but also cyclophosphamide and corticosteroids, a cyclical regimen, and calcineurin inhibitor, and plus or minus rituximab. And the very high risk, the most of the data is on alkylating agent therapy, so chlorambucil and cyclophosphamide, but cyclophosphamide is recommended given the side effects of chlorambucil over here. And again, we can follow the PLA2R antibody levels now, and based on PLA2R level antibodies, if they're absent or low, for example, so they may start off as being positive. Over here, for example, you give them therapy, there's no change. You can then increase the therapy by switching different agents or further enhancing the therapy you had. So let's say if you give them rituximab, give them additional doses of rituximab. If things are mildly stable or so they're increasing, then you can add additional therapy. If they're improving, then really you can back off on the therapy. So now you can follow these titers to determine where you are with respect to therapy, as opposed to just following proteinuria, because we know that the proteinuria will actually take years to resolve. So how do these drugs work? Well, they're rituximab really, as most of you know, is a anti-CD19/CD20 agent targeting eventually targeting B cells, but eventually preventing the formation of antibodies by plasma cells. Cyclophosphamide is a broader agent affecting both T cells, B cells, adaptive and innate immune system, so much broader over here. Calcineurin inhibitors can affect T cells. However, the thinking is that they actually help stabilize the actin cytoskeleton, and that might be the major mechanism of action. And that might be the reason why once you stop this agent, there's a higher risk of relapse as compared to rituximab and cyclophosphamide. Again, these are the different regimens that we tend to use. The cyclophosphamide cyclical regimen is really quite toxic, but we give whopping doses of methylprednisolone, a gram IV for 3 days, and then continue on with prednisone 0.5 milligrams per kilogram on months 1, 3, and 5, and cyclophosphamide at 2, 4, and 6. There is a non-cyclical version of it. And so the safer therapies have now been rituximab, and this is what KDIGO is targeting, is to use rituximab for those patients who are moderate or higher risk. CNIs can be used as an adjunct or for moderate risk patients. Again, for kidney transplantation, so the thinking is that membranous will tend to occur if you're PLA2R positive and you go in as a PLA2R positive. There's a high risk of recurrence of almost 50%. And really, the idea is to try to control this disease before they hit kidney transplantation to minimize the risk of recurrence. If they're negative going into the transplant and the antibodies have disappeared, then there's a low risk of recurrence, despite the patient still having ongoing proteinuria on dialysis. And we can look at serology versus staining for PLA2R on the biopsies. If the biopsy is positive, they shift over to being a medium risk, despite the serologic test being negative, as it's felt that the biopsy perhaps is more sensitive. So just to kind of go back to the case over here, the 49-year-old male who presented with intractable volume overload and anasarca. So he was progressing at a rapid rate. He was tried on multiple therapies, including my favorite plasmapheresis, which did not work over here. He was actually tried on bortezomib. He ultimately was progressing so fast that we actually had to do a medical nephrectomy by giving him actually NSAIDs and aminoglycosides, and then he eventually ended up on dialysis. He's up for a kidney transplantation, and in fact, his PLA2R was persistently positive, and even throughout dialysis, he was positive. We gave him rituximab. He finally turned negative after 3 doses of rituximab, and he actually just recently received a kidney transplant and is doing well with no evidence of recurrence and no evidence of PLA2R positivity. The 61-year-old male with proteinuria of 22 grams per day, albumin of 19, who had presented with a pulmonary embolus. So he's been PLA2R positive, again, tried on rituximab and CNIs. He did not really respond to either therapy. His creatinine was markedly rising. It was up to almost 300, starting off with a baseline of 110. Plasmapheresis him, and he actually had an excellent response to plasmapheresis with his PLA2R levels trying to come down, and we put him on cyclophosphamide. He's finally turned PLA2R negative. His creatinine is stabilized at about 220. And so the aim is over here is to provide ongoing immunosuppressive management with another antimetabolite. The 71-year-old female with a proteinuria of 2 to 3 grams per day I've seen for years with normal albumin. She's been anti-PLA2R negative, and really over here she has membranous. Yes, she's anti-PLA2R1 negative, and really I just have her on a bit of an angiotensin receptor blocker, and just been following her for years. So this is the different presentations of membranous. So I hope I've gone through and given you the story over the last 50 years with a great understanding of this disease and the significant changes in diagnosis and specific management of membranous nephropathy, as this is the understanding of the disease has led us to this. There's so much more to learn over here, and you can see this field is evolving rapidly, but we still need to learn about cancer and the hypercoagulability. And there is the further area of research is why the break in tolerance. So maybe with that, I'll stop and entertain some questions over here.
Thanks, Azim. We got a couple of minutes. Great talk, very thorough, really excellent update. Dr. Rocha has a question. I'm going to just allow Dr. Rocha to speak. So if you want to ask your question. Dr. Rocha, are you there? And if you are, you can unmute yourself and ask the question. And maybe Azim, you could have a look at the written questions and answers.
Yeah, I'm just looking at the gut Herzls here.
Why don't you just address them there, because the people can't see them.
Okay. So I have Greg's question. Demonstrate how the immune system plays a crucial role, but can we protect the kidneys by other mechanisms such as blood? Yep. So absolutely, Greg, you're right. We're using ARBs over here. So the conservative management would be using ARBs. There was a recent study that included some patients with GNs with the SGL2 inhibitors, specifically dapagliflozin. So we do tend to use that as well. We don't tend to use protein restriction as much, at least I don't. But salt restriction is the major way to go. And then if they're not responding to that, and the proteinuria really hasn't improved, then we start considering immunosuppressive agents. As far as the mechanism of hyperlipidemia, so it's felt that there's two things. One, you're losing the lipid carriers in the urine. So the proteins that go in the urine, as well as what you're doing is the liver is bouncing back and creating an increased number of lipids, and there is a significantly increased cardiovascular risk in these individuals who are nephrotic, and so we do pay attention to placing them on a statin and bringing those levels down. Herzl, are you saying more membranous in cancer? Oh no, I didn't make any mention about checkpoint inhibitors, Herzl. At the present moment, I don't know if, I mean, depends on the type of cancer that they have. If the oncologist wants to use checkpoint inhibitors, that might potentially worsen their disease, but obviously the treatment of the cancer would be the more important aspect over here.
And Azim, maybe make Alistair's point the last one, because we should wrap up. It is 9 o'clock.
Is there long-term survival data only for that? So Alistair, you're absolutely right. Long-term survival comes from Ponticelli and regimen. So this is, they're looking at 10-year survival that showed that a marked reduction of kidney progression to kidney failure, about 8 to 11%. And so compared to just a conservative therapy. The KDIGO, Alistair, suggested they recognized this, but felt that the therapy Ponticelli regimen was just so toxic with the combination of previously chlorambucil and cyclophosphamide and the whopping doses of corticosteroids and other complications of corticosteroids that they actually suggested rituximab as the agent of choice, unless if they're very high risk, in which case we should use rituximab. There was a retrospective study that was done looking at cyclophosphamide, because I really think that's really the main drug. I don't think the steroids are adding that much more, so we don't have to give them those whopping doses of steroids. And that was based on the vasculitis protocol of giving IV cyclophosphamide, and they actually, considering it's retrospective, showed fairly good 1 to 2 year survival with respect to membranous and going forward with a reduction in proteinuria. So that's becoming a more popular way of giving cyclophosphamide as opposed to the traditional Ponticelli regimen.
Okay, thanks very much, Azim. Tour de force, great presentation. As everybody knows, this will be on the YouTube channel later on today if you wish to watch it again and maybe take some notes. I'd like to thank Azim for putting together rounds, which obviously took a long time and were extraordinarily thorough and a really great review. We'll return with the usual chairs grand rounds in a week from now. Dr. Verhovsek and Dr. Azam will be looking after those. And in 1 month from now, we will return for chairs grand rounds. Thank you, everybody, for watching. Have a great day and get ready for more snow this afternoon. Thank you. Bye.
Thank you, everybody.